We have an excellent session this morning about coronary physiology and imaging. I don't know if you hear this, it's going to be in Greek. Hope your Greek is good. We'll have the question and answers in English, but for the rest of us, it's going to be in Greek. But we have a great panel today. Dr. Arnold Seto from California, Dr. Yiannis Chatzizisis from Omaha, Nebraska, and I am from Minneapolis, Minnesota. And this covers the whole physiology and imaging. And as you've seen on the innovation session yesterday, this is a topic that is very debatable. There's a lot of controversies right now. I think we've had, in the last couple of years, a major shift in our performance. Before that, I think the term FFR was self-explanatory. Now we have adenosine FFR, now you're doing resting indices. There's a lot of confusion out there about what each one of those are. So I think after this morning, you have no more questions because we'll explain everything. So before we get started with Dr. Seto, he'll talk about the new tools, explain to us what those resting indices are. We want to make this very interactive, so please feel free to stop us, ask any questions. If you don't ask it, you'll forget it. So by all means, have plenty of time, and I want to make it as interactive as possible. So thank you very much, and Arnold, thanks for kicking off.
Yeah, good morning. I'd like to second that. It's definitely much more, it's a small session, and we also have the ability within the time to actually feel free to interrupt me. It's the short answer. Just interrupt me if you have any questions, because in the other sessions, we don't have as much time to allow for that. My disclosures are as follows. I'm getting a Boston Scientific honoraria, done some research for Assist and Philips. So just wanted to go over the background in coronary physiology. Why do we need hyperemia in the past? Why was at the center of all of our physiological measurements, FFR, all the outcome data with FFR, and the new things in the past 2 years, of course, have been the IFR or resting indices and the outcome studies, therefore, from the defined flare and IFR sweetheart. The advantages of possible IFR and FFR pullback, and then the latest things are DPR and other resting indices. So this is actually one of the critical slides and probably one of the centers of all the debate at this point. Why do we use hyperemia? And when you go back to the original dog experiments from Gould in the 70s, what he would do would be apply an external constriction to a dog model, where he would actually apply a 50% stenosis, a 60% stenosis, a 70% stenosis. And what he found was that at 50% stenosis, you had no change in resting or maximal flow. But that resting flow was only reduced when you started getting to a constriction of about 85% diameter stenosis. However, you could demonstrate reductions in maximal flow, so-called coronary flow reserve, and you could demonstrate that for as early as 60% diameter narrowing. This is how we got to the angiographic correlate of about a greater than 50% stenosis, at least had the potential to demonstrate ischemia. And that's why historically we don't stent anything less than 50%. We shouldn't be stenting anything less than 70%. And that's how we get to our angiographic nomenclature of always naming something that we stent 80% or more, and anything we don't stent as 50% or less, even though really angiographically we can't tell. These are the coronary flow velocity curves. On the severe stenosis, you can't manifest a high velocity because your pressure gradient will increase with each increase in flow velocity. In the absence of any stenosis, your pressure gradient will not increase with the increasing in flow velocity. The more modern version of this is that the increasing flow velocity with hyperemia will tend to spread out your pressure gradients, such that your FFR gradient will be as high as 37 for a moderate stenosis. But for that same stenosis, for PDPA, it will only be a 10 millimeter gradient, and for IFR, it will be a 13 millimeter gradient. So these have this can have an impact if your precision on measurement is limited. Why do we use physiology at all? We of course know about the anatomical functional mismatch, things that we see that look tight in this case, or look intermediate in this case. What looks like a hazy lesion of 70% may actually have more or less physiologic import than we might think, because of entrance angle, exit angle issues, as well as flow separation. How big is the distal artery? So there's many factors hemodynamically for why this would be more or less stenotic than you actually think. So FFR was derived from these original curves. We do all stress testing. Nuclear stress testing always requires hyperemia, and so FFR was derived from this basis. FFR is derived from the concept that aortic pressure is the same along the entire length of a normal vessel, and that resistance, V equals IR, resistance is always equal to the change in P, the pressure gradient, over the flow. So that means the flow is equal to the change in gradient, delta P, over the resistance. So if you define FFR as the myocardial flow across a vessel with a stenosis, divided by the myocardial flow QN without a stenosis, then these two end up being here, the PDPA minus P pressure of the vein divided by the resistance. And so a critical part of FFR was that only at maximal hyperemia could you assume that the resistance of the vessel with the stenosis is the same as the one without the stenosis. And so if RS equals RN at maximal hyperemia, then FFR, or QS over QN, could be approximated as PDPA. So in other words, FFR kind of relies on hyperemia to work mathematically. And so that's why there's a lot of resistance from the FFR community when IFR and other indices were developed. So FFR, of course, is well demonstrated from the FAME study of 1,000 patients. After a 2-year follow-up, they demonstrated a reduction in MACE of 5%, and the 5-year outcomes and 10 years outcomes of this study are subsequently available. Most recently, the FAME2 trial was, the 5-year outcomes were published. This was a trial of stable angina patients. And for the first time, you could demonstrate that not only could PCI have a benefit in terms of reductions in urgent revascularization, MI, and death, but for the first time on the individual endpoints, you could actually show a reduction in spontaneous myocardial infarction. So this is the anti-courage. For those of us who are interventional cardiologists, we don't like courage, but we like this study because it says that if you could stent the most severe ischemic lesions, you could potentially prevent a spontaneous MI. So this is a revolution, I think, and a justification, what we've always been looking for in terms of can we prevent MIs by stenting. Now, it's not definitive, but it's at least highly suggestive that we can prevent MIs for at least stenting the most severe lesions. So why don't we use FFR more often? Many of us are now. I mean, it's gone up from 10% to probably 20, 30% of PCIs. But there's still some issues. There's still a clinical context. There's still some uncertainty around FFR values in STEMI or ACS, severe LVH, elevated EDP. All of these can affect how accurate the FFR it may be. There's also technical issues. Drift, the traditional piezoelectric crystal wires from St. Jude and Volcano, they're not the best, and they have a lot of drift, sometimes as much as 0.8, and then you have to repeat the measurement, which is very painful. It can also vary. The FFR can vary by up to 0.03 with repeated measurements. And then there's poor guide wire performance, well below the typical workhorse wire. A lot of these have been addressed with the latest technologies, especially Boston Scientific's Comet wire, which uses Sahi technology on the guide wire performance, and also optical technologies. There's also the issue of hyperemia in general. With adenosine, you get some symptoms, AV block, a lot of variable responses. Some people are highly responsive to adenosine, others are not. And then it's time-consuming for multi-vessel FFR, especially if you're trying to run a 2 or 3 minute infusion each time, stop it, and then restart it again for the next coronary artery. Very challenging. So Justin Davies, about 10 years ago, developed this concept that perhaps we could identify a region or time in diastole where there's no waves in the coronary artery, and that the resistance to coronary flow was naturally low and stable. And he identified this period shortly after the dicrotic notch called the wave-free interval, and it uses pressure only. So as you can see by these coronary flow diagrams, the resistance appears to be relatively stable and low at this period of time. And this study, this concept was tested and published last year, the Defined Flare and IFR Sweetheart study, as part of the Defined Flare study. And this is 2,500 patients in Defined Flare and 2,000 patients in IFR Sweetheart, randomized 1-to-1 to FFR-guided revascularization or separately IFR-guided revascularization. Instead of comparing one with the other and always having 2 measurements, you actually were forced to measure one or the other. And this is purely an outcome study with 30-day, 1- and 2-year follow-up, and we're about in 2-year follow-up range. And essentially, IFR that was less than 0.89 was found to be comparable to an FFR of less than 0.8 by using the endpoint of a composite endpoint of death, MI, or unplanned revascularization. And this was shown in these Kaplan-Meier curves, demonstrating that the hazard ratio in the two studies was actually quite identical and clearly non-inferior to each other. The pooled endpoint was also non-inferior. So you had this potential benefit of having non-inferiority compared to FFR with 10-fold fewer procedural symptoms or signs, with less dyspnea, chest pain, fewer rhythm disturbances. Of course, if you don't give adenosine, you don't have any of these. It also found that they reduced the average procedure time by 4.5 minutes, and those of us who've used IFR can definitely attest to that for many lesions you could quickly measure, and I actually measured a 3-vessel IFR just last week in about 5 minutes. So I was just quickly switching over using a common guide and was able to do so. The treatment allocation with IFR and FFR could bring up some concern in terms of it does give you different answers. About 20% of the time, the IFR and FFR will differ. And so that meant that there's actually 10% fewer revascularizations with IFR. So this could be a plus. In Britain, they said, oh, this is great. You can have similar outcomes with fewer PCIs. But those of us in America who might want a stent, you might say, that maybe something I might not want to do. So this is something of interest, but because it gives you slightly different answers, 20% of the time, the revascularization may differ as well. So going back before these studies, there was correlation studies that showed that, as I mentioned, IFR and FFR tend to correlate only 80% of the time. And the difference is the discordances tend to happen in patients who are around the borderline, where the FFR is like 0.80 or 0.79, or the IFR is 0.89. And I think one of the questions is, perhaps we can't show a difference in this range because they're borderline ischemic anyway. We used to use a 0.75 cutoff for FFR. Now we use a 0.80 cutoff. There's no real reason why it needs to be one of those or the other. It's just that one is a little more conservative than the other. And perhaps our outcome studies are starting to show that the benefit of PCIing something in the 0.79 range for FFR may be unclear. What about the FFR advocates would like to say that the IFR or DPR, how do they compare with each other? Well, it turns out that they're very close. If you measure the whole cycle PDPA, pressure distal versus pressure arterial, that the IFR is actually very close to that. They have actually a formula, PDPA equals 0.32 plus 0.67 IFR, tend to be a very close linear correlation. This has been repeated in 1,000 vessels in Korea, and they found that the correlation value is 0.97. And this formula was 1.37 times the resting PDPA minus 0.37 was equal to the IFR. So if you had a close and linear relationship with IFR, then maybe you don't need the IFR technology and proprietary software. Maybe you could just use the PDPA. And that's one question that they had. In this particular study, they said that IFR had a slight benefit for each increasing increment of lesion severity, whether you define that increase in lesion severity by diameter stenosis, basal stenosis resistance, hyperemic stenosis resistance. There was a slight increase, larger percentage change in IFR than PDPA, but this is fairly modest and not quite clear that it made a difference. So that's for whole cycle PDPA, though. However, it includes the systolic waveform, and that may introduce some artifact. All of these measures, IFR, PDPA, FFR, have about the same correlation to some external measure of ischemia. The best measure of ischemia, potentially non-invasively, is ammonia PET or oxygen-labeled PET. And these correlations have consistently been moderate, 70% to 80%. Dr. Kern has a slide where it always says 80%. Everything's correlated to each other by 80%. And nothing can get to 90%, 95%. You can never get perfect agreement amongst these things. And one of the questions is, can we ever get to perfect agreement? Is there any gold standard to ischemia? Many people will say that FFR was the gold standard for ischemia. It's not a slam dunk for me anymore. I mean, the guidelines are starting to say that FFR is still the gold standard. It has the most evidence behind it. But I think that all these measures have some degree of a suggestion of what ischemia is. So the latest thing that has been developed just last year by Vantveer is that they've identified that the wave-free period, demonstrated here by the IFR on the top, Actually numerically can be estimated by almost anything in the diastolic period, the so-called diastolic pressure ratio. So if you take any PD over PA over diastole, it turns out that you'll actually have minimal differences numerically from IFR. So they took 257 vessels from the Verify-2 study. They actually took the pressure waveforms, plugged it into the Volcano proprietary software. They got a number, and then they measured it separately, and they found that there were minimal differences, less than 0.01. So if you already have an error rate of 0.01 to 0.02 in your measurement, then this is 1/10 of that. So if there's any differences, and they're well below your coefficient of variation for measurement, and there's a correlation to IFR of greater than 0.99, then this is essentially the same test. Essentially then, that IFR doesn't measure anything special during the wave-free period, that any diastolic pressure ratio would be sufficient. And if you look back on on Nico Pyle's original paper, when they measured FFR, we measured the entire whole cycle PDPA during hyperemia. And even back then, when he developed FFR 20 years ago, he would have said it would have been best if we only focused on the diastolic period, because that's when coronary flow happens. But he didn't have the technology to do that. And so now we do electronically, and it turns out that perhaps you don't even need hyperemia. Maybe this is accurate enough that you don't need hyperemia. You get equivalent outcomes with resting diastolic pressure ratios. So, Boston Scientific is filing an FDA application to add DPR, the diastolic pressure ratio, to their FFR console, and they demonstrated in a number of 97 patients that their waveform gives the same outcome, that the DPR is always equivalent to the IFR, and they're submitting this to the FDA for approval in the fall. And so the advantage of this is that, unlike the original IFR algorithm, you don't need the EKG, and that there's no need to identify the dicrotic notch. And their protocol averages it over 5 beats. So it has some advantages over the original IFR protocol, and it's basically numerically equivalent. So to summarize the diastolic pressure ratio, the question and the conclusion is that the wave-free period of IFR doesn't necessarily provide unique properties, and you don't need the EKG to define it. And all versions of DPR provide the numerically equivalent values to IFR. And so if it's numerically equivalent, then you don't need to do another outcome study. Some people might argue, oh, you haven't really proven this. You need to do another 4,500 patient study. And basically, if it's numerically equivalent, then you probably can apply the existing randomized trial evidence to this measure. And that was actually recently added to the correction to the AUC, or appropriate use guidelines, and basically the correction took out the brand name of IFR and replaced it with ratio of distal coronary to aortic pressure without hyperemia. Any resting ratio, either PDPA, whole cycle, or diastolic, and basically substitution of these newer pressure ratios could be used. They actually endorse that FFR is still the gold standard. However, I think if the outcome studies are still equivalent, then I think there's some debate over that. So let's go back, now that we talked about DPR, which one is still better, pressure or flow? These two curves you just saw, one of the questions is that for particularly mild stenosis, when you have FFR discordance, the IFR might be 0.93, but the FFR, which is a non-significant stenosis, but the FFR is 0.73, which indicates a significant stenosis. And Gus DeWard presented this slide, and I'll show you a couple examples of this, where the mild stenosis, if you increase the flow enough, will drive the FFR low below 0.8. And give you different answers. And when you think about what ischemia is, if ischemia is really differences in flow, then a high flow state, a CFR of 3.2, really isn't ischemia. We wouldn't think that that's ischemia, but yet FFR says it would be. And so this hyperemic value might overestimate the significance of this lesion.
Can we ask on this, because I think that's confusing for
Yes.
people. So who are these people? I mean, here you're saying that they have a mild stenosis, but yet they increase their flow so much. Are
Right.
those the marathon runners? I mean, who are these people that can do that?
Right.
Does it matter for them? Or is it just more of an artifact, so to speak?
So the IFR advocates would say that this may be an artifact, that you have hyperemia and they happen to be a hyper-responder to adenosine, and therefore the FFR is driven lower than than it should be. Meaning that the flow has increased so much, the CFR is 3 instead of 1.7, that you actually make it, it's an artifact essentially. These are a minority of people. Less than 10% of all FFRs would have this, but it happens in these very mild stenoses, proximal high flow states. Tend to be younger patients, people who aren't taking caffeine, and I'll go over essentially with adenosine, you're looking for people who are either hyper responders or poor responders. We know what causes poor response. Caffeine causes poor response, and MI causes poor response. Dialysis patients have a poor response to adenosine. In contrast, people who are younger, people who have proximal left main left main or proximal LAD lesions, they tend to have high flow states, and these are where the discordances happen most. So I'll show you a few samples. We'll get to those. But yeah, this is a critical slide, and thank you for stopping me there, because this is where you're going to see the difference, and this is the only explanation they believe for why there's discordance, because of differences in adenosine responsiveness. What is happening to the CFR? So when you're taking all these measures, I think the question is, what is really ischemia? And I think of it as a dartboard. All these tests are imperfect, again, trying to get to the gold standard of ischemia, and none of them are perfect. And when you look at the evidence, all of them are, the heaviest evidence is still with FFR, but increasingly all these things are correlated to each other, and it's not clear exactly where the truth lies. Let me move forward a little quicker. I'll let Emmanouil go over this slide, where actually, you have about 17% of signals on FFR will have just evidence of signal drift. This is in the gold standard. This is in a core lab from the contrast study in 616 patients, and they found a lot of issues. Up to 20% of patients had issues with their measurements. So quality of the measurement really makes a difference, perhaps more than which type of measure you take. So to take good quality pressure measurements, I tend to try to disengage the guides, use optical technology, don't use small guides, and potentially FFR may be more resistant to drift because it spreads the values more than IFR and PDPA. So to summarize this portion, IFR differs from FFR in 20% of cases, but is non-inferior in outcomes. PDPA is usually, but not always, equivalent to IFR. DPR is numerically equivalent to IFR. FFR can be quick and easy with IC adenosine. I do that routinely. And pressure measurement quality may be more important than which measure you choose. So not to get into Emmanouil's talk too much, but when do I use adenosine-free indices? I do it as an initial screening for everybody. But anytime someone has a contraindication to adenosine, bradycardia, COPD, dipyramidal use, an inadequate response to adenosine, at ACS, people who are caffeine drinkers, LVH, diabetes, CKD, or end-stage renal disease, adenosine-free indices may be better for pullback or multiple lesion assessment because it's just faster, and you don't have the potential interplay of multiple lesions. When you have tandem lesions, the hyperemic flow, when you treat one of them, increases, whereas the resting flow tends to stay the same. Therefore, treating one lesion will make the first lesion look worse after fixing that second lesion, whereas the resting ratios, it's much more predictive. If you get the interlesion pressure of 0.91, it'll probably stay 0.91 after you fix the distal lesion. And that's why these, at least non-hyperemic indices, may be more useful in tandem and or serial lesions. And that was demonstrated in this study published this year, the IFR gradient study, which showed that you could predict what your IFR would be after fixing a single lesion by using the pressure pullback technique and finding that that you could, basically you could predict what it would be, and the error was very low, 1.4%. So that's the potential advantages. So when you have multiple lesions or a need for a pullback, consider IFR or DPR. If you're short on time, actually, like we all are, consider IFR or DPR. If any of these are borderline, use FFR. Or if you want a complete evaluation, I do everything. And whichever one you choose, which one do you do? Which one do you listen to when you have discordances? Well, I'd like to say you pick the data that you want. If you want to fix it, then pick whichever one is positive, because they're both limited in their ability to determine what's positive, and you might be able to pick the data that you like. I like to say it gives you 2 swings at the bat. Whatever you do, use physiology and attention to technical details. Just a couple quick cases. This is a case of saphenous vein graft where the IFR and FFR differed. You have a very focal-looking lesion, looked like a valve initially, and we put a wire down. The volcano wouldn't go because it's a poor quality wire. The run-through went down easily. We put in a cyst catheter. The resting ratio is 0.98, indicating no significant stenosis, but the contrast FFR is 0.89, which may be a question mark. With adenosine, IC adenosine, the FFR is 0.69, indicative of a highly significant stenosis. So which one do you listen to? The PDPA of 0.98, which is normal, or an FFR of 0.69. Well, the outcome, when you did an IVUS on this lesion, you found this highly significant 86% stenosis, very focal. They tend to be very focal lesions that have wide exit angles. These are the ones that tend to have IFR, FFR discordances. So do you want to treat this or not? Most people would want to treat this, right? And so this is an easily treated lesion. You balloon it, you take care of it, and then afterwards, both the IFR and the FFR are normal.
Actually, it's a good point of vein grafts. Since the natural history is different, actually, should people be doing even FFR in vein grafts, or should we just step in?
So very good question. There's not much good evidence on using FFR in vein grafts. However, there's no reason to think it'd be significantly different. The myocardial bed is the same either way, but the outcomes may be worse, of course. Great question. Here's another case of a native vessel, distal right, large focal lesion in the mid to distal right. IFR is negative at 0.94, FFR is markedly positive, 0.78. What do you do with this lesion? Well, again, focal lesion, very easily fixed. Go ahead and fix it. FFR becomes 0.98 afterwards. I believe that I've done something different. Even though I'm an IFR advocate, I don't think it has all the answers, and so you fix this one. This is a case I did on Wednesday, very distal right again, calcified lesion, very focal. So this is the opposite problem. This guy's on dialysis. He has prior CABG. He has microvascular disease. So he is not going to have a great response to adenosine. So sure enough, his IFR is markedly positive at 0.81. The pullback suggests a fairly significant stenosis there, and it's very focal. But the FFR, it goes down from 0.84 to 0.82. You get very minimal changes in pressure with adenosine with dialysis patients. And these patients, I think, the IFR will be more accurate. So sure enough, I tried to fix this, and I couldn't get a stent across because it was calcified, but just after a heavy ballooning, I got the PDPA up to 0.95, already up from 0.84 to 0.95, and I think I did this guy a favor. Last case, actually I'll skip this last case. Any questions?
Using nitroglycerin prior to any of your measurements?
Yes, absolutely. You should try to use nitroglycerin before all your measurements because it reduces the wire spasm. From all these wires will potentially cause spasm. I use it at least half the time. Usually some patients I don't will be people who are already hypotensive.
Why can't you use a diagnostic catheter? And the wire's so small.
Yeah, good question. If you think it's going to be negative, should you use a diagnostic catheter? And I have done that. I've even done it without heparin, heaven forbid. But that's only when I really thought it was going to be negative. Now, of course, there's always a risk of damage to the vessel by wiring. And so if you go in with the diagnostic catheter only, you might be getting yourself in trouble. Hemodynamically, it shouldn't make a difference. It's a smaller bore catheter, so you might have more damping. But if you flush it correctly, then yes, theoretically, you could use a diagnostic catheter.
What's the normal hyperemic response to exercise? So how many times, if you're on a blue stage 6, how many times should their CFR go up?
Yeah, great question. What is the normal hyperemic response to exercise? So adenosine, theoretically, in a normal individual, should go up to 3 to 5 times you're resting. And exercise is only supposed to go up to 2 to 3 times. But of course, it increases demand at the same time, so it's a much more physiologic measure. Now, what is really a normal CFR? No one's really determined that. We think that CFR should be greater than 2 as the cutoff. But the normal response for hopefully all of us younger people is 3 to 5 times. So that's the problem with the adenosine measures. You're actually gaining, just a theoretical thing, you're gaining resolution by spreading out the values, but you're also throwing in a chaos factor of adenosine responsiveness. You don't know what each individual's personal response to adenosine is going to be. And so you may be losing that precision by tossing in this factor of adenosine, even as you're gaining it on the pressure side. Excellent questions. Sorry, I've gone over time.
This is perfect. Great. Well, thanks very much. That was an excellent presentation. So mine will actually build on what already heard from Dr. Seto, and will try to answer a question that many actually people didn't even think there was a question even a few months ago. Just curious, in the audience, how many people actually use IFR? Okay, so most people. How many use PDPA? Okay, so a couple, three. How many people don't use physiology, just use intravascular imaging for determining severity of stenosis? Okay, so the minority, good. Well, you shouldn't, I'm kidding. But as you know, for assessing severity of lesion, except for left main, where obviously imaging is good for left main, the IVUS and that area, but for the other, for determining severity of lesion, physiology is the way to go. So you've heard there are many, many different tests. These are my disclosures. And we'll just do a brief overview and discuss once again which one to do when. Now, when you say FFR, actually, I started changing my reports. Now I say adenosine FFR, which is funny we should say that, but as you may have heard already, there's the contrast FFR. If you give contrast, contrast by itself has some vasodilatory effect on the microvasculature. So actually, you do get some drop in pressure and some spread in the pressure. It's not quite as much as the drop in pressure you get, the flow you get with adenosine, but still, that's something you can do. So you heard about the derivation. Any questions you have, Dr. Seto will answer them. And it's been, and as you know, even FFR, which we consider as the gold standard, if you look at the original validation study, which now it's been, 22 years, it wasn't perfect. So there was false positives and false negatives. There's not a perfect correlation between FFR and ischemia, but non-invasive testing. At the same time, non-invasive testing is not perfect. You all know if you do nuclear stress testing, that's not perfect as well. So although we consider FFR the gold standard, let's not forget the validation was done compared to non-invasive imaging, and that has limitations as well. And also, the other thing we should not forget is the original cutoff was 0.75. It's not 0.80 that we're using right now, and many people are still having questions why we move from 0.75 to 0.80. But as I'll show you later on, that is the area where the benefit may not be as much as when you have clear-cut low FFR values. And you've seen this already. If you defer lesions based on an FFR, if you go long-term, and this is the 15-year follow-up of the defer study, the original study that deferred, there was a very low event rate in the deferral group. If you think about FAME1, that there were significantly less events for people who underwent FFR-guided PCI, and then, of course, FAME2, significant reduction in events, including myocardial infarction, which has always been the concern for the cardiac-friendly people, that you reduce revascularization, but that's not a strong endpoint, but everyone agrees that myocardial infarction is a strong enough endpoint, so hopefully that takes away some of that problems. So contrast FFR, as mentioned before, if you give contrast and then you go back to pressure, wait for 1 or 2 seconds, and then record, you're going to get a measurement which is not FFR because it's not adenosine. Adenosine is the better vasodilator, but you're still going to get drop in pressure. And this is from Niels Johnson. If you go less or equal to 0.83, that correlates fairly well with the contrast FFR, with an area under the curve of 0.93. So that's another option. If you do a resting index, IFR or DPR or PDPA, and then it's kind of borderline, one thing you could do without having to give adenosine would be to do contrast and then look at the contrast FFR, and then if it's 0.83 or less, then you're going to be ischemic with a fairly good correlation with the adenosine FFR. Does anyone do contrast FFR from the people here?
So you're still clearing the catheter with saline and everything else?
Clearing the catheter with saline, taking a picture, taking a picture, flushing, 1, 2, record, and record as you do any other adenosine FFR with bolus. I must say, in our lab, we have this problem in which adenosine can only be fixed by pharmacy, IV adenosine. So we never do IV adenosine because it takes 15 minutes to get the IV band. So if we're going to do adenosine FFR, we'll do it with just intracoronary injection. And the problem then you cannot do pullback because it's not long enough to do that. So the contrast FFR is another way to do this, but I think what you've heard before about the serial lesions, the resting indexes sound better. But again, that's something it's easy, simple, and available to everyone. So nothing to lose to keep it in mind. And then in terms of the non-hyperemic indices, now I know coffee is a problem. However, people are NPO, right? So I think realistically, unless it's an emergency, which is unlikely you'll be doing, less likely to be doing imaging, that caffeine is less of an issue. But you do have absolutely the end-stage renal disease people, you have diabetics, LVHs, there are issues with the microvasculature, this may happen. Now, in terms of contraindication to adenosine, does anyone here would not give adenosine because of concern with comorbidities? So a couple of people. For COPDers, or is that the main thing? And I would say that I agree with you, when especially for IV adenosine, then that's the one that you can get in trouble, get into a issue with asthma attacks. So that's the one area where I get a little nervous. But the reality is, for IC adenosine especially, the chance of getting this is fairly low. But nevertheless, why push it? And with the resting indices, you can do this as well. You've heard that obviously if you do the resting indices, you are going to be faster, and you're going to make the patient not have to feel bad. And even now, when I give adenosine FFR weight, 10-15% of the time we'll get this complete heart block, and usually we'll give 200 mics in the LAD, and then you'll be 5 seconds without any QRSs, and the lab is going crazy. So there is, adenosine is good, but adenosine does have some side effects, and we've had VF arrest because you have 5 seconds pause, and then the R falls on the T, and then you follow. You had actually AFib as well. You get the pause, and then you go into AFib, and of course that doesn't do the patient any benefit. So adenosine is good, but adenosine is not completely risk-free. It's low risk, but it's not completely risk-free. So obviously, if you can do it faster, less risk, and cheaper, because adenosine has a cost, that's a good thing as well. And you can see that the cost is significantly less with adenosine. And you've heard about the wave-free ratio and the benefits of diastole. And you also heard that there's a fairly good correlation, about 80% between the IFR and with the invasive FFR. How many of you believe that the outcomes data from Define Flare and Sweetheart do apply to any resting index? No one. So no one would do. No, so you'd only do IFR then. Who would only do IFR because there is the randomized control data from these two trials showing there. So you would never do anything else. So you'd only use the IFR, the Volcano system to do this. Anyone? So then, who believes you can use any resting index with similar outcomes?
I think if you define, if you took a diastolic pressure index, if you do any resting index, that includes PDPA, and it seems be a little more poor quality. I think if you took a diastolic resting index, it'd probably be equivalent.
Well, to have democracy, you have to vote.
I think we all agree. The question was confusing.
Okay, so let me rephrase the question. How many of you are comfortable using PDPA instead of IFR, and believing the outcomes you're going to get are going to be similar to what you get with IFR? No one. How many think that DPR or the diastolic index would be equivalent? Okay, well. All right, well, maybe we should hold the session. But that's actually a good point, because I think that comes to the data. So the question is, and I see your point. So, someone did a trial with 4,500 patients, and that's important, of course. But you've seen all this correlation data, right, that you've seen before, that there's correlation 0.99 or 0.98 between DPR, diastolic pressure ratio, and IFR. So if it's essentially very similar measurement, you still wouldn't use it because you don't have the outcomes data. And I'm not saying there's right or wrong answer over here. This is more of a personal approach to things. All right? Well, let me show you some cases. I think the most information comes when you look at, I'll tell you my personal approach, when you look at both. And I think many of us have done both resting indices and FFR in the same patients. So this is a patient we did recently. You see the patient has long kind of intermediate lesion in the circumflex. Doesn't look particularly tight, but does have some lesion. And then you look at the PDPA, it's 0.88, and then we did bolus adenosine FFR, and the FFR is 0.76. So there's concordance here. You can make an argument that the 0.88 is fairly close to the 0.91 cutoff we typically use for PDPA, but nevertheless, both are concordant. The same patient, you look at the LAD, and there it is a little more convincing. The resting PDPA, which again is the full diastole PDPA, is 0.82, and you see the waveform here. And one way I personally use is if I see the waveform being deformed during diastole, you have the separation during diastole, I'm obviously more convinced that this is real. You still can get drift and issues, technical issues, or dampening of the pressure with the guide, and that's even more important, as you've heard, for the resting indices. But if I see this nice separation during systole, it's fairly close, and then during diastole, we are having separation of the pressures, I feel fairly confident that there's something real, and of course here it's confirmed. So 80% of the time, they're going to be concordant. And the ones that are not going to be concordant are going to be the ones that are kind of in the zone of 0.75, 0.80 FFR. And as I'll show you, the data for benefit for revascularization for those patients is actually not as strong as the ones on the lower end of the spectrum. So the question is, even if you miss some, and maybe one FFR is going to be 0.75, and the IFR is going to be 0.93, or the PDPA is going to be 0.81, and you leave 0.91, and you leave them alone, are you really going to have more events down the line? And that's been the concern, obviously, with Sweetheart and defined flare.
How much did the right coronary ischemia affect the LAD?
That's an excellent point. So CTO, this is near CTO. Actually, we made it a CTO when we intervened on it. But we know that if you have a CTO in the donor vessel, you're going to have a lower FFR because you're supplying the territory of the occluded vessel. However, the amount of that is not very much. About 0.03 to 0.04 is the average difference that if you do the FFR after you fix the CTO. So if you do the FFR here in the LAD, and here it was 0.76, there is a chance, if you fix the right, you're going to increase by 0.03, 0.04. You're still going to be on the ischemic range, so this LAD probably will have to be fixed. And actually, in this particular case, probably fix it up front, because if you go retrograde, you don't want to be messing with ischemia in the donor vessel. Now, if you had an FFR of 0.80 in the donor vessel, and then you have a CTO, that's the area where you may fix it, may go to 0.83 or 0.84, and then you might not necessarily need to fix the donor vessel. But that's an excellent question. I don't know if you guys have seen that, or if you do that. That's, again, 2 papers you have looked at that. The concern, of course, is that you are intervening. If you don't fix the CTO first, you have more risk. If something goes wrong on the other side, then you have the high risk of the procedure because of the other problems. So once again, you've seen this. 80% is the concordance. Resting indices, IFR, PDPA, you're going to have about 80% concordance on the measurement. So it's the 20% that matters. There was actually a post hoc analysis that was published in Circulation showing that maybe there's a trend for more events in those patients. But every post hoc analysis, it's really hard to look at as well. You've heard about the diastolic pressure ratio already, and that makes sense. Instead of taking the whole cardiac cycle, you take diastole. That's where the cardiac flow happens. That makes perfect sense, and you've heard already that this is similar. You've seen that the correlation is close to 0.99, 100%. And for all the resting indices, it is the same. So what to use when? The big difference between the FAME studies, which was the FFR validation, is that the risk of the patient was significantly higher, the baseline risk from that of the patients in defined flare as Sweetheart. And that's, of course, has to do with the inclusion-exclusion criteria. The people who got into those studies were lower risk than the ones who got into the FAME. And the reason is because FAME got multivessel disease, right? I mean, multivessel disease, and you did FFR to decide who to treat or not, versus on the other one, it was intermediate lesions, not necessarily the extent of disease that you had in the FAME trial. So the event rate was 13% versus 7%, 6% on the fine flare. So people are still thinking that for the high-risk patients, then FFR might be the preferred way to go because it's validated and there is much more to gain. Do you believe that? So for the high-risk people, would you do FFR more? Okay, so more people are nodding. The other subgroup of people that there is less correlation between the resting indices and the FFR is the left main. So for left main, there was significantly less correlation. So left main with resting indices may be a little harder to accurately determine. It might have to do with larger area of myocardium that is being supplied. But nevertheless, I think most people agree that for left main, you probably want to do FFR, and also has to do with a certain way. You want to do FFR in both the LAD and do it in the circumflex as well. And you're going to give IV adenosine, and you're going to do a pullback because you usually have disease in the LAD and the circ. And if you don't do a pullback, you may have disease in the LAD and the circ, and it's not left main in reality, but you think it's left main. So, and the third thing, you're going to pull your guide back instead of having engaged, because you have osteo left main, you may have dampening. And what's dampening going to do to your FFR? Is it going to come up or is it going to go down? So it's going to artificially increase your FFR, so essentially underestimate the severity of your stenosis. So you're going to have for left main and essentially every osteo lesion, you're going to make sure that the guide is disengaged and is well flushed. And you've heard this scenario. There are actually people in whom resting indices are going to be better, more accurate than the FFR. And these are the people with the so-called superflow, younger people, those with LVH. So in those people, you may not have significant stenosis, but if the flow goes way up, and again, adenosine is not a physiologic way, it's not exercise. Exercise is great, but many people cannot do it. Then the resting index may be actually more accurate than the FFR. The key thing is to do it properly and always do a pullback and confirm that there has been no drift. Now, with the newer wires, the drift is significantly less. So with the Comet, there is much less drift than there is with the older versions. But nevertheless, the impact of drift on the resting indices is going to be way more than on the FFR. So like every other test, it's easy to interpret, but it's hard to do. And you're going to take your time. You flush the guide well. You equalize where you're supposed to. And then you pull the guide back from the coronary ostium. So there's absolutely no dampening, no interference with the measurement. At the end, you confirm that, yes, there has been no drift and that my ratio is the same as 1 when the guide comes back. How about people who have jailed side branches? How many people here use FFR or any index for the jailed side branches? You do a PCI, you jail your diagonal, and then you're not sure should you stand it or not. Are many people doing that? Well, if you don't, maybe you should, actually, because quite often the lesions look bad. You stand a diagonal or an OM, and it looks bad. And then you do the, FFR. FFR is going to be not significant in 80+% of those cases. So in geographic, the visual estimate is not quite as good in the jailed side branches. So for this, again, we don't really have much validation for resting indices. So that's, again, one area where probably FFR is the way to go. And we talked about this already. There is the issue, again, with the discordance between IFR and FFR. Any of you would ever do Doppler for assessing coronary flow reserve? Or? No, and I think most people clinically, they don't do it because it's much more, it's the Doppler wire, which people don't use, just much more cumbersome to use. But most people use just the standard FFR. You've heard about this before, that now it's not just IFR based on, I think what the group is not convinced, but based on the new AUC guidelines, they do say that having the resting indices now is a group effect versus the IFR only, even though, as you acknowledge, you do have the outcomes data much more with IFR. And this is one meta-analysis Neil Johnson did this a few years ago. And what it shows you here is that the benefit you get in terms of MACE is more in those people who have the lower FFRs. If you go around this area, 0.75 pain-0, actually the benefit you get from revascularization with either PCI or bypass versus medical therapy alone is not that different. And that is why it's my argument, what I'm doing more, apart from the convenience part, which you cannot argue against, it's much more convenient to do a resting index. The part is that even if I miss some people, and I know that in some people I may misclassify them, they may be borderline ischemic, or they may be borderline non-ischemic, I may misclassify them based on a resting index, but I think the impact on them is going to be minimal, because even if you revascularize them, the benefit is going to be minimal. The major benefit is in the more ischemic patients. So my personal practice has been that the resting index is being done well. It's going to give you the answer in most of the cases. And if you're in the gray zone, then you can either treat them medically or give adenosine and do a regular adenosine FFR, or do a contrast FFR and try to clarify this anymore. That's another way. You can go both ways. If you have a really low rest, you can go sequentially. If you have a really low resting index, you're going to be probably ischemic. And then you can sequentially go give contrast, give adenosine to finally misclassify those patients. So, to summarize, everyone has their own practice. My practice has been that for most lesions, I'm now switched to resting indices. I would do actually all of them, depending on the wire we're using, but if I have IFR with IFR, if I have PTPA, I'll use PTPA. I used to be fairly skeptical for PTPA, so I've done a lot of PTPA, and then I would do adenosine, just to do the adenosine FFR. And actually, I've done several cases, I have very few where I have discordance, and usually it's minor discordance between the two. So I'm fairly comfortable for more lesions to use the resting indices. The exceptions are left main, the very complex multivessel disease patients, and jail side branches, in which I'll be more inclined, I'll go and do FFR, give adenosine in those particular patients. So again, thank you very much. I don't know if you have any thoughts and questions. Theoretically, you could, but I always get nervous. Did the drift happen at the end? Did it happen in the beginning? So for me, I would do it again. And of course, the problem there is now you have to rewire the vessel, and if you spend 20 minutes some vessels are very hard to wire, and then if you spend a lot of time wiring it, now you have to do it again, that's not a pleasant thing. And that's one of the advantages of the newer wires. The other disadvantage of the IFR is very validated, but the wire is not good. For complex lesion, it's hard to get the wire there. If it's a simple lesion, it doesn't matter, you can get anything. But for complex lesion, it's not. So for the newer wires, you're easier to deliver them in those more complex areas.
You mentioned the technical problems with IV adenosine, and we have the same pharmacy has to mix it its own time. Have you tried Lexiscan for that?
We tried, and pharmacy called us and what are you doing? This costs $1,000. It's actually more expensive. It's nice because it's obviously a single injection and you have hyperemia for a while, but it's even more expensive than adenosine. So, we did this in a few months.
How much is that in the capital?
Well, I'm with you. But if you have access to that in your lab, it's great. But it's in most labs I've seen a lot of resistance because of the cost, and people don't think. The pharmacy doesn't think about the cath lab cost because their budget is on the drugs. And that's unfortunately that the silos we have, some of the departments don't necessarily talk to each other. Yeah.
Does anemia affect these indices?
That's an excellent point. So you're suggesting that because of anemia, your resting myocardial flow is going to increase to some extent. Good question. I don't know. I don't know if you have any, if you know.
I don't think it does, but yeah, it's a great question.
Because the 70% lesion, the original study was based on normal hemoglobin. So as the hemoglobin goes down, the severity of the lesion goes up, right?
Yeah, I think it makes perfect sense. The problem is how do you convert? So let me put it this way: if you have anemia, and you do a physiologic assessment, and actually it's normal, I think you're okay. Because if anything, what's going to happen, you're going to increase your resting, you're going to have more flow, right, at rest. If you don't have significant pressure drop despite higher flow, you're fine. So if it's within the normal range, I think you're done. The question is, if it's abnormal, is it abnormal because of the anemia increasing the resting flow, or is it because of the anemia? And that's the one area. Maybe actually, again, I'm just thinking, I don't know for sure, but giving adenosine in this, you can see how much more you can increase it, and doing a real adenosine FFR, maybe that's the more accurate way to go. That's a great question, actually. Maybe that's a good thing for a study.
Yeah, I think it depends on how you define
I guess the argument is you should not be doing but, does anemia affect it?
But you can do bypass, right? So
Right.
now, unfortunately, I don't think we can bleed people so you can see the effect of anemia. And most people who come to the lab, they usually hemoglobin is replenished. But that's a great question. I agree.
And I think nuclear scans will come up a little more positive than anemic people. We've all seen it. They get sent in, and now they're anemic, they get worked up. And I had ladies say, "Can we repeat my test?" And I said, "Sure." And we did the nuke again. It was normal the second time.
Perfect.
If it applies to the renal failure patients, they have borderline hemoglobin, not from bleeding.
Have you seen any cases? Have you had any experience with these people? Have you seen any cases where you had discordance in
There
this?
has been, I think.
Yeah.
The lower they get, as they get to 9, the less, and you start wondering if it's true.
Yeah, no, I think again it's an excellent point. Well, I think because we're getting closer, I'll have Dr. Chatzizisis present, change a little bit gears and talk about intravascular imaging. No, whenever. This is 8:30, so don't.
Okay. Good morning, everybody. And where's the mouse here, Manos?
Just go down button.
Where?
Just go from here.
No, I need the mouse as well so that I can show
Oh, it's
you.
here.
Okay, good, beautiful. So, high definition is catchy, and it sounds like everything nowadays tends to high definition, and why not IVUS as well? So let's see what is this high definition, how this looks like, and to what extent this is going to be a game changer. This is my disclosures. So I'm not going to get deep into medical imaging physics, but there are two fundamental features that determine the quality of intracoronary imaging. The spatial resolution, which is essentially the ability we have to distinguish two adjacent points. And obviously the smaller the distance between those 2 points, the higher the spatial resolution. And the second feature is the depth, which is the far field, the ability to see in the far field. And you can obviously see here very nicely, very evidently, how the transition from standard definition to high definition changes the spatial resolution. We can even see distance between 2 rocks, whereas we don't see it here. 2 more features. Spatial resolution has 2 components, the axial and lateral resolution. What is axial resolution? Axial resolution is the ability to distinguish between 2 points across the length of the ultrasound beam. What is lateral? The ability to distinguish between 2 points which are perpendicular to the ultrasound beam. So this is the list of the intracoronary imaging modalities over the last 20 years. We have the IVUS, the OCT, near-infrared spectroscopy, Raman spectroscopy, intravascular MRI, angioscopy, thermography. And taking everything together, the best combination of resolution and depth is culminated into the IVUS and OCT. So those are the 2 modalities at the end which dominated the field of intracoronary imaging. And there has been an ongoing battle between the IVUS and OCT in terms of like resolution and depth. So with IVUS, we get great depth and modest spatial resolution. With OCT, we get great spatial resolution, extra resolution at the range of 10 to 20 microns. It's almost equivalent to pathology, but we unfortunately get very poor depth. So the ideal intracoronary imaging modality should be the one with the best spatial resolution and the best depth, but obviously in reality this is not easy to happen. So this is the evolution, the history of IVUS, started like 25 years ago, and in mid-90s you can still appreciate all those blurry images of the coronary arteries back in mid-90s. And over the last 10 years, essentially, there has been a plateau in the evolution of the technology of IVUS. 10 years ago, the OCT was introduced, which raised the bar of intracoronary imaging, and now it sounds like the IVUS is trying to hit back, with the introduction of the so-called high-definition 60 megahertz IVUS. And obviously, as you can see here, the high-definition IVUS gives us a comparable resolution. This is an in vivo swine carotid experiment, and at the same time, the IVUS high definition gives us great depth. We can cover up to more than 6 millimeters depth versus OCT, which covers up to 1 millimeter in depth. And this is the comparison across the board between the standard definition IVUS, the high definition IVUS, and the OCT. So IVUS uses ultrasound, OCT uses near infrared light. The X resolution with the traditional IVUS was more than 40 microns. With a high definition is double better spatial resolution, but still worse than the OCT. The penetration, as we said, has been the big advantage with IVUS, more than on average 6 millimeters, versus the OCT, which has a very poor penetration in the range of 1 to 2 millimeters, so we cannot see in the near field, in the far field very well. With the advent of high definition IVUS, now we have stronger blood speckles, stronger backscatter from blood, and this is something that we always need to consider. And of course, the big advantage with IVUS has been the fact that we can assess remodeling, we can see the plaque burden in the far field versus the OCT, which just gives us the lumen interface. And those are the technologies we have nowadays in terms of like high definition IVUS. We have the OptiCross family from Boston Scientific. We have the assist devices. Infrared X also has a limited market release product, and Volcano is also attempting to get into the field. And again, the reference here at this point is the OCT, which is almost equivalent to pathology. And this is the OptiCross, the design of the OptiCross high definition catheter. This is a rapid exchange catheter, which this mouse doesn't work well here. And I'm trying to, sorry about that. Yeah, so the, you see it's a rapid, oh, beautiful, okay, thank you. You saved my day. So this is the rapid exchange system. The big advantage with this new technology is that the tip is very soft and it can allow better crossability for difficult anatomies. 5 millimeters from the tip, there is this radiopaque marker. 15 millimeters proximally from the radiopaque marker, 20 from the distal tip, there is the transducer, the source of the ultrasound, which emits ultrasound with 60 megahertz, and the whole transducer is pulled back within a sheath. So let's walk over some clinical cases to see how the high definition IVUS performs in native atherosclerosis and in stents, using the OCT, as I said, as reference. So starting from the normal wall, you can very nicely see the anatomy of the 3 layers, intima, media, adventitia, by OCT of normal wall, and we can even measure with a high detail the thickness of the intima adventitia. And also with the high definition IVUS, we get more or less very comparable appearance of the structures and also measurements. This is an early fibrotheroma. You can appreciate the area, lumen area at 4.9 here in this particular case. Those are all from our own repository of clinical cases. You see the fibroscap, a high backscatter structure overlying the lipid pool, which is with a low backscatter, low signal, and the fibroscap measuring at 400 microns. So coming to the high definition IVUS, pretty comparable lumen area, you can very nicely see, similarly sized, the Echo Bright fibroscap overlying the lipid pool, which is echolucent. It's free on lipids and it's echolucent on the IVUS imaging. This is a thin cap fibrotheroma. You can appreciate the thin cap measuring 90 microns by OCT, and the acellular low signal void necrotic core by OCT. And now with the advent of high definition, we are we have the ability to also see the thin fibroscar by IVUS as well, by ultrasound. I think this is a major breakthrough here, measuring more or less at the same range of 10, 100 or 90 microns. And then you can appreciate the echolucent necrotic core. And this is from another case, but I provided here just to show you how with this high resolution OCT and IVUS imaging we can come close to the pathology. This is now another interesting case. So what is this cavity? Thoughts? We have a cavity. What is this? We have a cavity, we have a layered structure, we have a thin fibroscar, we have an echolucent area, which is a necrotic core, and then we have another another bright area, high signal, and then again low signal. So we have a layered appearance. This is as Emmanouil indicated, it's a healed, ruptured thin cap fibroathyroma, and here is the annotation. This is the old necrotic core. This is the old fibroscar, this layer here. Then this plaque ruptured, it healed silently, and it developed a new necrotic core, new plaque built up on top of this, and covered by the new thin fibroscar. So it's a thin cap fibroathyroma which at some point ruptured and it healed, and it evolved again to a thin cap fibroathyroma. And the beauty here is that we can appreciate all those structures, those thin structures by IVUS as well. And here is the annotation. So this is the old necrotic core, this is the old fibroscar, this is the cavity. See the similarity between those two structures, those two modalities, and then again the thin fibroscar. So this is advanced thick cap fibroathyroma. You can appreciate similar lumen sizes, thick fibroscar with both modalities. But the big advantage with the high-def IVUS here is the remodeling, the positive remodeling, the depth, the ability to see in the far field versus the OCT, which at this point it cannot allow us to see where is the external elastic laminar border. This is a fibrocalcific plaque, a thick fibroscar by OCT and by IVUS, one-to-one correlation, and then the chunk of calcium here, well defined, separated by the fibroscar by OCT, and shown as a shadow behind a very bright structure on the high definition IVUS. Clot as well. I hope you appreciate this small structure here close to the wall. This is a white clot which is rich in platelets, no fiber, no red blood cells at this point, no shadow in the OCT terminology. And then let's see what we can see by IVUS. Will we be able to pick it up? I'm telling you, the standard definition IVUS would never be able to see this structure. Let's see if the OCT can see it, if we're lucky enough. Oh, come on, this video has to play. This is the only video that I would love to have here. So it was there. It was there with this high resolution imaging and with IVUS. And if you don't believe me, I can show this to you later on. Dissection. So very nicely, you can appreciate the intimal flap here and entry of blood into the area under the intima, just at the take of this branch. Now coming to stenting. How the high-definition IVUS performs in stenting. This is a very nice review by Dr. Mehara, and they summarized here the differences, similarities, and differences between the two modalities, the OCT and the standard definition IVUS. So you can appreciate that at different stages of PCI, the pre-PCI stage, post-PCI, and the follow-up. So at the pre-PCI stage, the major focus is the stent sizing, essentially coming from the vessel sizing. And obviously, IVUS performs better than the OCT, because with IVUS, we have better ability to see in the far field and assess the media to media distance. Now, coming to the post-PCI, The major focus is to assess for for tissue protrusion through the struts, for strut malapposition, and for stent edge dissection. And obviously, OCT gets points here. With the standard definition IVUS, we don't do very well in assessing those structures, those side effects. And then at follow-up, we need to know what is the nature of the wrist stenosis, whether it's neointimate hyperplasia versus neoatherosclerosis. And with IVUS, unfortunately, we cannot, standard definition IVUS, we cannot do that, whereas OCT gives us this information. Of course, IVUS has a point by giving us information about remodeling after stenting. So let's see how the high-definition IVUS can help us with the PCI at several stages, pre, post, and at follow-up, and how this can change the existing state of the art. So first thing, as I said, we need always to correctly size the stent, and this requires media to media measurement. And this can happen obviously very nicely with IVUS, but the problem with IVUS is, as shown nicely in this study, is that we always tend to slightly overestimate the distances, the lumen measurements compared to OCT. OCT, on the other side, gives us better, more accurate measurements, but it cannot show us the far field, it cannot show us the media to media. So we always tend to undersize the stent. So hopefully there is good data which show that the high definition IVUS can bridge the gap here. It can give us the media to media distances, and at the same time it can give us accurate measurements. Also, we can use IVUS to help us assess the left main bifurcation anatomy and potential PCI planning. So this is a very cool case. This is a patient who came in with a stress test positive in the LAD and circumflex territory. You can see obviously here extensive disease, mostly the proximal sides of the left system. And we would like to get a little more information, anatomical assessment of this left main LAD circumflex. So we started with an OCT shown here. So we advanced the OCT, but as you can see here, I have it captured live. At this curve, which was very highly calcific, we couldn't advance the catheter more. So due to the OCT catheter design, we ended up having our transducer into the guide. So this is the transducer of the OCT, that's the distal part, and that's the transducer part, captured, trapped into the guide. So we couldn't get any imaging. We then switched to the high definition IVUS using the high definition IVUS catheter, and as you can see here, this is dying. Sorry. Yeah, I need to have to be able to control this. Yeah, beautiful. Okay, and as you can see here, with the high definition IVUS, we advanced the tip of the catheter essentially to the same point. We still couldn't go through this calcific curve at the LAD. However, because the transducer in IVUS is at 20 millimeters from the tip, we were able to sneak the transducer into the proximal LAD and get some imaging. And here is the imaging. So we had actually the same problem with the circumflex. So this is the, on the left-hand side, the LAD to left main, full back, and this is the circumflex to left main. And you can see very nicely a very calcific stenosis at the osmotic LAD, and that's very nicely coming the circumflex on that side. We can see very nicely with high resolution of the bifurcation, and same from the circumflex to left main. So it gives us important information, high resolution information about the anatomy of this left main, and this is very useful for the anatomical assessment and further planning of this potential intervention. Post-PCI, we can assess the struts. We can see the struts with the high def IVUS very well, as shown here, and we can then measure the distance from the wall. And at follow-up, we can obviously assess the wrist stenosis by OCT. This is a case from our clinical cases, which is in-stent wrist stenosis secondary to neoatherosclerosis, versus no intimal hyperplasia, so we can assess the mechanism, and this mechanism is also assessed nicely by IVUS giving us, the high-def IVUS giving us similar measurements of the wrist stenosis. So how the OCT, coming back to the initial concept of OCT versus standard definition IVUS, how the OCT now compares to high-def in IVUS in stents. In post-PCI, now we get points, we get greens here. We can better see the, comparably to the OCT with the IVUS, the high-definition IVUS, the strat malposition, the tissue protrusion through the strats, and the edge dissection. And also at the follow-up, now we can better assess the wrist stenosis and the nature of stenosis, whether this is related to neoatherosclerosis or neo-intimal hyperplasia. And where we move forward, what's next? So already in the technology, we have the 4K ultra high definition, which makes the full high definition looks outdated. What's next in the IVUS? For now, let us enjoy the high definition. The high definition IVUS is here. It's the state of the art at this point in the technology of this modality, and along with OCT is the state of the art in intracoronary imaging. And intracoronary imaging, and allow this personal comment here and final comment, brings interventional cardiology to the next level, to a higher level, where we can use advanced technological breakthroughs to do fine job in the cath lab versus in and out, quick plumbing based on eyeballing. So in conclusion, the high-def IVUS and OCT are the state of the art in intracoronary imaging in 2018. The HD IVUS provides comparable resolution to OCT, but has better depth, and that's a big advantage. The HD IVUS identifies, as I showed you nicely, all the histopathologic stages of atherosclerosis, including the thin cap, rupture-prone plaques. The HD IVUS can facilitate in the cath lab the stent sizing and thereby optimize stenting. The HD IVUS is particularly useful for the assessment, as we said, of ostial coronary stenosis when OCT cannot, due to inherent limitations, cannot perform well, or when it comes to complex left main calcified bifurcation anatomies, as I showed you earlier with this cool example. And then finally, the high definition IVUS becomes an interesting alternative, attractive alternative, when contrast load comes into consideration. So with that, I would like to thank you for your attention.